I want to discuss one more. Hi, first of all, it's me, Dr. Mohammad Kazafi, and you are listening Dr. Mohammad Kazafi Views. And basically, I'm a neurosurgeon, and secondarily, I am a spinal surgeon. But I want to discuss one very important topic with you. It is a short topic, but it is very important. In that regard, it is called the second impact syndrome. And this second impact syndrome, I just want to present you like that. This second impact syndrome is a condition on which an individual experiencing a second head injury before completely recovering from a prior head injury. And it is thought that the athlete who sustain a concussion and return to their sports early are at exceptionally high risk. So, though the second impact syndrome is a relatively rare condition, individuals who have experienced or are at risk of experiencing a head injury should be educated about the risk associated with sustained another head injury before recovering from a prior injury. So this activity describes the pathophysiology, evaluation, and the management of the second impact syndrome and highlights the role of the interventional team in the management of the affected patients. So the objective of this to identify the patient at risk for second impact syndrome based on their clinical history and evaluate patient for a sign and symptoms of the second impact syndrome. Access and damage to the complication of the second impact syndrome, develop and implement effective interprofessional team strategy to improve outcome for the patient with head injury. So these are the very important things which I wanted to discuss with you. First of all, second impact syndrome, SIS, second impact syndrome, is a condition in which an individual experienced a second head injury before completely recovering from a prior head injury. And second impact syndrome has recently gained increased attention as many places the athletes sustaining a concussion and returning to the sports early as a being particularly at risk. So, though it is relatively are conditions where physicians should be aware of the second impact syndrome or SIS and educate patients who have experienced or are at risk of experiencing a head injury as the syndrome is often deadly. The term second impact syndrome entered the medical lexicon in 1984 when Saunders and Harburg wrote on the article for this topic and describing a case report of the football player who died 4 days after suffering a head injury after he returned to play on the day of his death, and he collapsed and died after presumed second head injury. Etiology I want to discuss with you for these kind of patients. There have been very few confirmed cases of SIS to date. Therefore, the exact incidence, risk, and pathophysiology of the condition are unknown. According to the Center of the Disease Control and Prevention, is estimated that 1.6 to 3.8 million sport-related concussion injuries occur only in United States of America every year. While the etiology of concussion is generally understood, the etiology of second impact syndrome is not well understood. So we have to understand the second impact syndrome, which is not well understood up till now. The purpose of this presentation, what I am presenting in front of you, only for that you should understand the second impact syndrome, which is already has been neglected. The generally accepted cause related to a second concussion before the brain has a chance to recover from the initial insult fully. So, the athlete will rapidly develop altered mental status and loss of consciousness within seconds or to a minute, or you can say in a matter of time of the second hit. When they are getting a second hit, when they got the second hit, and after a minute or few seconds, they get the loss of consciousness or altered mental status, so resulting in a catastrophic neurological injury. The devastating injury results from the dysfunctional cerebral blood flow autoregulation and leading to an increase in an intracranial pressure, and the pressure rapidly develops and eventually results in brain herniation. The herniation may occur either medially across the falx cerebri or inferiorly through the foramen magnum, resulting in brainstem injury and rapid deterioration and leading to the death within 2 to 5 minutes. So, it's a very serious condition. If somebody is dying during play and within a minute, I think it's in a serious medical condition, and we have to understand. Once we understand, we can teach or propagate to the other people. A recent case report shed some light on the injury pattern. An athlete returned to the hitting drills 5 days after his initial concussion, and he had a routine CT scan on day 4, but had a persistent severe headache. After getting hit at practice on one day, later he collapsed several plays, and later after complaining of the headache and not being able to feel his legs. So, what do you understand? The second CT scan done in a local emergency room demonstrates the bilateral but thin subdural hematomas. However, a subsequent MRI demonstrates the caudal displacement of the midline suture with injury to both thalami, resulting in a transtentorial herniation. So, we have to understand what kind of dangerous could be. So, the epidemiology, a review article in 2016 completed in a PubMed research and found only 36 cases reported in 15 publications and 17 cases meeting in inclusion criteria. The characteristic of an athlete susceptible to the second impact injury were male gender and aged between the 13 to 24 years, and contact sports like American football, boxing, and the ice hockey. Just want to explain you, they are telling hockey, we are telling ice hockey. So these are the sports could be dangerous for the concussion injury. Only 7 of the 17 received a direct blow to the head, and the other were thought to have received a blow to the body and the force transmitted to the head. Computerized tomography demonstrate the diffuse cerebral edema while midline shift, leading to herniation in 4 of the cases. Additionally, all of these cases had either thin or moderate subdural hematomas. So, 2 of the cases had a subarachnoid hemorrhage and 3 suffered as a ischemic stroke. So there is a genuine organic injury inside the brain after the second impact syndrome or so. So we have to take it very, very seriously. Now I want to discuss with you a little pathophysiology about this case. So patients who have experienced a concussion show a poorly understood but complex array of neural, metabolic and iconic changes. So the mechanism of injury seems to be associated with axonal shearing. This causes rapidly depolarization, neurotransmitter release, and ionic shift where potassium ion leaks extracellularly and are replaced with sodium and the calcium intracellularly. This results in dysregulation of the cerebral blood flow, leading to the edema, and this increased glucose utilization combined with the injury related decrease in resulting cerebral blood flow create an energy mismatch. All these changes which I showed or which I put in front of you, all these changes require time and energy for a return to normal transmitter physiology. Generally this is thought to make about 7 to 10 days, but maybe longer in younger athletes. So the metabolic abnormalities after an initial concussion may leave the brain more susceptible for the further injuries. So, the history and the physical exam of these kind of patients is very, very important. Any athlete who has returned to play after a concussion should be watched carefully even if they had an appropriate recovery period and completed a return to play protocol. But a concussed patient will report any combination of the symptoms include the headache, nausea, memory loss, dizziness, blurring of vision, confusion, fatigue, photo or phonophobia, motor or sensory loss, poor hand-eye coordination, or emotional irritability or lability. So these things you have to consider. So as I am mentioning, this concussed patient will report any combination of the symptoms include headache, nausea, memory loss, dizziness, blurring of vision, confusion, fatigue, photo or phonophobia, motor or sensory loss, poor hand-eye coordination, or emotionally irritable or lability. So we have to consider it seriously even though we had the history of the injury of the head or concussion. On physical examination, the patient may have an altered level of consciousness, retrograde or post-traumatic amnesia, but generally difficulty concentrating and balance seems to be the consistently impaired. Additionally, there may be a sensory or motor abnormality or visual abnormality, so we have to take it seriously and we have to do the proper physical exam. So this proper physical exam showed us there is an altered level of consciousness, retrograde or post-traumatic amnesia, but generally it is difficulty concentrating and balancing seems to the consistent impairment. Unless the player have been knocked out, if they remain on the field of the play, they may show the sign of ataxia, running in a wrong direction or slowed reaction time, and he is not performing appropriately. So keeping on the field is not a good for the team and even though for the patient or the player, which I consider the patient. A concussion have been more widely recognized and the complications related to the insufficient recovery have become better recognized. Sideline evaluation have developed. Sideline evaluation of cognitive functions as an essential component necessary to assessing this injury. Brief neurophysiological test batteries that assess attention and memory function are practical and effective. Such tests include like that SCAT5 or we can say SCAT5, SCAT5 or SCAT5, which incorporate the Maddox question and the standardized assessment of concussion. For an athlete who has collapsed with the susceptible SIS or glaucoma score, papillary reactivity, deep tendon reflex, upper and lower extremity cones, and the presence or the absence of the Babinski reflex can be done before transport or upon arrival at the emergency room. So these considered as a serious form, as a serious head injury. As I mentioned here, for the athlete who has collapsed with the susceptible and we can say the secondary impact syndrome, a Glasgow Coma scale score pupillary reactivity, tendon reflexes, upper and lower extremity, clonus, and the presence or absence of the Bibinus reflex can be done before transport or upon arrival at the emergency room. Due to the challenges of that constitutes a second impact syndrome, the lack of research and the rapidly progressing nature of the condition, it is challenging to provide the sound guidance on an appropriate history and physical exam. Perhaps clinicians should change their mindset and think every concussion they see, especially in male athlete aged 13 to 24, could be second impact syndrome, and observe the injured athlete closely for progressing sign or symptom. Evaluation, how could you evaluate? Even though I mentioned a lot of things, but evaluation, again, it's a very, very important part of this lecture. Obtaining a thorough history is critical, and evaluating a patient with a susceptible brain injury, though the patient will unlikely to able to provide a good history, one should gather as much as information from those who may have witnessed the incident. It is essential to determine who the injury occurred and if there is any seizure or concussion history, if alcohol or illicit drug uses was involved, whether or not there was any loss of consciousness, any resultant weakness or paresthesia, difficulty walking, or incontinence of the bladder or bowel. Patients who have experienced significant injury or loss of consciousness, continued symptom, deterioration in neurological functions, or neurological deficit should be evaluated with imaging studies. Screening for alcohol or illicit drug would be recommended. CT is the preferred imaging modality for acute head trauma. It is a more sensitive imaging modality for detecting acute hemorrhage than a non-enhanced CT, provided better delineation of the bone and is more sensitive in detecting acute hemorrhage and defining any surgically reversible injury. Current guidelines recommend a CT for a susceptible skull fracture, intracranial bleeding, or other intracranial disorder based on the physical exam finding, since second impact syndrome injuries generally cause loss of consciousness. It would seem prudent to start with CT scan of the head. So the current guideline recommend the CT for the susceptible skull fracture, intracranial bleeding, or other intracranial disorder based on the physical examination finding, since second impact syndrome injuries generally causes loss of consciousness, and it would seem prudent to start with the CT scan of the head. Treatment and management like that, the management of the second impact syndrome is limited due to the limited understanding of the condition and the lack of research and the controversial nature of the condition, and the management of the secondary impact syndrome start with prompt recognition of the sport-related concussion and protecting the athlete until they recover from the initial injury. The current treatment guideline consists of relative rest, both cognitive and physical, and then graded return to play. This should be supervised ideally by a team physician and experience in managing concussion and athletic training staff. The athlete should not be cleared to return to the full participation until they have completed a return to play protocol and the medical staff give clearances, such as subarachnoid bleed. I want to repeat this sentence. The athlete should not be cleared to return to full participation until they have completed a return to play protocol and the medical staff give clearance, such as subarachnoid bleed, ischemic stroke, subdural hematoma, skull base fracture, or skull fracture. So if they clear these things, okay, they can go further and join the team. Deterrence and the patient education, primary prevention seems to be the most logical answer for the second impact syndrome. Parent and athlete should be educated on the potential complication of the concussion, symptoms, expected time, course of the recovery. This would include discussing the potential problem related to returning to play too soon, including prolonged recovery, persistent symptom, and second impact syndrome. As I'm telling here, the encouragement from the parent and the coaches will help the athlete avoid minimizing symptom and returning to play too soon and appropriately. Most return to play protocol will take at least 7 days before the athlete is cleared to participate. So, enhancing the healthcare team outcome, how we can enhance the healthcare outcome. The diagnosis of concussion remain a clinical one, and it is based on constellation of symptoms. Because of this, the team physician experience in evaluating and managing concussion should be recommended, and interprofessional team with clear communication between the athlete, parent, coach, athletic training staff if available, and the physician or the nurse practitioner would be essential. It appears it is the time a second impact syndrome is a preventable injury, and it is thought of an athlete is to allow the full recover from an initial concussion and not to allow to return to too quickly, and the second impact event will be unlikely to occur. And a school nurse should participate in the education of the patient and their family. If the player goes down on the field from the suspected head injury, the on-field medical staff, emergency personnel, and the emergency room should communicate clearly to optimize the care of injured athlete. Standard communication tools like the SBAR will allow for the efficient and the clear communication among the healthcare team. This one patient, the same like from the Australian cricket team, and he got a severe head injury with the fast bowler. The ball hits on the head, even though he wore the helmet. He was with helmet, but he got a significant concussion and he died because of that. So in that regard, it is a good sports and a good play. The positive thing should not harm the patient in that manner. I hope I wanted to clear in front of you. I hope you will like me, subscribe me, and share me, because we need the encouragement from your people. Thank you so much.